Differentiate between different types of leg ulcers. Leg ulcers are due to breaks in the continuity of the epithelium, which do not heal or heal slowly due to an underlying pathology. There are three common types of leg ulcers: venous ulcers, arterial ulcers, and neuropathic ulcers. Arterial ulcers are due to insufficient blood supply due to a peripheral artery disease. Venous ulcers are due to pooling of blood and waste products due to venous insufficiency. And neuropathic ulcers are as a result of peripheral neuropathy, mostly caused by diabetes mellitus. There are several key features that can help distinguish arterial, venous, and neuropathic ulcers. Arterial ulcers are typically seen distally at the tip of the toes or the dorsum of the foot. The skin changes are pallor, dry skin, loss of sweating, loss of hair, and shiny skin. In arterial ulcers, there will be absent pulses, and the skin will be cold to touch because of the lack of blood supply. The size of arterial ulcers are smaller than venous ulcers. They have a regular outline, a punched-out border, and the depth of the ulcer is deep. The floor of the ulcer will lack granulation tissue, therefore will look pale, and they may also have a necrotic eschar. The skull will also look dry and will be less likely to bleed. Arterial ulcers are severely painful, and the pain worsens when the patient is lying on the bed or when elevating the leg, and it improves with lowering the leg, because gravity improves the blood supply to the leg. Lymph nodes can be palpated if the ulcer is infected. Venous ulcers, on the other hand, typically occurs in the gaiter area. Gaiter area is the area at the inner side of the ankle above the medial malleolus. It is where venous hypertension is the highest. The skin changes seen in venous ulcers are lipodermosclerosis, hyperpigmentation, eczema, and varicose veins. You will be able to palpate pulses in venous ulcers, unlike arterial ulcers, and the skin will be warm to touch due to pooling of blood. Venous ulcers are much larger than arterial ulcers. They have irregular borders, sloping edges, and they are more superficial than arterial ulcers. The floor of venous ulcers will look pinkish in color due to the granulation tissue, and the ulcer will be wet and more likely to bleed. Venous ulcers are mild to moderately painful. Pain will be relieved by elevation of the leg and worse when lowering the leg. Lymph nodes can be palpated if it is infected. Also, Magellan's ulcer, which is a type of squamous cell carcinoma due to long-standing ulcers, may be seen in venous ulcers. However, in arterial ulcers, Magellan's ulcers usually do not develop because patients seek treatment early due to it being severely painful. And this squamous cell carcinoma happens when there is a long-standing ulcer. Next, moving on to neuropathic ulcers. Neuropathic ulcers are typically seen at pressure points, like the heel of the foot or head of metatarsals. There can be clawing of toes and a flat foot due to the neuropathy. You will be able to palpate pulses in neuropathic ulcers, just like venous ulcers. And the skin temperature will be normal to touch. Neuropathic ulcers are smaller than venous ulcers with regular borders and punched out edges. They're deep and penetrating with a yellowish slough. They usually dry with no discharge. Neuropathic ulcers are painless due to the damage to the nerves. Lymph nodes can be palpated if the ulcer is infected, and Magellan's ulcers can also be formed in neuropathic ulcers, just like in venous ulcers. Now let's move on to the investigations. Ankle brachial pressure index can be used to assess for arterial disease. An index of less than 0.5 indicates critical limb ischemia. A digital subtraction angiogram can be done to find the location of the arterial block. A duplex scan will be required to map the veins in venous ulcers. HbA1c levels and fasting blood sugar can be done to check for blood glucose levels. Nerve conduction studies may be needed in neuropathic ulcers as well. If the ulcer is infected, then culture and ABST is done. A skin biopsy may be required in patients suspected with squamous cell carcinoma. Now let's talk about the management of leg ulcers. Arterial ulcer management is same as for peripheral arterial disease. Surgical revascularization and pharmacotherapy with antiplatelet agents and statins will improve the blood supply and therefore heal the arterial ulcer. Management of venous ulcers include surgery for varicose vein, or if the patient is not suitable for surgery, then a 4-layer compression bandage to drain blood from superficial veins to deep veins will be done. Neuropathic ulcers are managed with special shoes to decrease the load on pressure points and treatment of the underlying cause. If it is due to diabetes mellitus, then treat the diabetes mellitus.